I want to thank Mark Wyatt for being one of the early supporters of mine to get me involved in quality improvement and leadership around, okay, what are we going to do with Saskatchewan's healthcare system? So it's been a fantastic experience. And of course, I am delighted to introduce my wife, Dr. José Géry, who's a miracle in my life. We were married this Easter, and I like to say I'm the luckiest man on the planet. We actually met on an online dating service called Lava Life, and my username was Lucky and Talented. So I was sincere about the being lucky part, and the talented part was a joke. But I'd had a wonderful life working and a wonderful career working with Sun. This is from a 1999 campaign that our organization did to sort of bring the nursing shortage to the public's awareness. We did a lot of research and promotion, and this is an example of some of the fun part where we actually asked nurses to deliver their used shoes to symbolize all the nurses who are leaving Saskatchewan to go to Alberta and BC. The only thing missing in my life was romance. My online dating reference to being lucky was, as I say, absolutely true, but the talented part was a joke. José enjoyed the humor, but when she came down the elevator to meet me for the first time at the airport, I flunked the love at first sight test. And that night when she admitted she wasn't attracted to me, I said the smartest possible thing, "Oh, that's okay, I could see you're going to be really high maintenance anyway." She demanded that I document my accusation, and I reached for her hand, apologized, and said, "I'm sorry, darling. Let's just be friends. It'll be fine." And over that weekend, as I demonstrated my genuine offer of friendship, she slowly changed her mind and decided to give romance a try after all. Within 24 hours, I had shaved my head and my beard because she said I would get a lot more kisses without the facial hair. So I must be really talented after all, because despite the rocky start and despite the fact that she threw me under the bus 2 more times over the next couple of months, here she is. So I must be talented. And given my terminal prognosis, it turns out that I'm the one who's high maintenance after all. Thank you, Graham. So I'd really recommend marrying a psychotherapist to each of you. Fellow health policy, yes, we can make it happen, let's just fix it, people. Positive energy, people, I call you. Given the backlash that you face every day, you can't possibly afford the sheer volume of treatment sessions that you probably need. José taught me the most valuable life lesson, and I think it's because she's missing the blame gene. So you can see us traveling. She invited me to Italy, to Florence, in order to figure out, okay, if we can travel together, maybe we can be a couple. So we ended up over the next 3 years going to Italy, Pompeii, the Czech Republic, hiking to the base of the Matterhorn, which I'm really proud of. And when we traveled and I made a mistake, there was no blaming involved. Can you guys imagine that? A wife who doesn't blame, or a husband who doesn't blame? So All there was, okay, what are we going to do to fix this situation? So what occurred to me is that individual organizations, like I worked for Sun all these years, and I know we became really good at representing nurses' interests. And individual organizations, whether it's the Health Quality Council or nursing or physicians or psychotherapists, are really good at representing their own organization, saying, hey, we could make the system better as long as you people did X, Y, and Z. So what I love about her contribution about no blaming is that if we reject blaming, then we can move forward. But we just have to absolutely say, no blaming other organizations. Everybody's caught in the same system. We're all trying to do our best. And I have a little joke about nurses and doctors coming up. But you folks are all committed to leading change. You're the positive energy people. You don't sit around blaming other organizations for our failure to reform the system. I heard a Jesuit scholar say that the 8th deadly sin is thinking you're right all the time. And combining some humility and open-mindedness with José's no blaming principle allows us all to focus on let's just fix what needs fixing. But I have to tease my physician friends a little bit. This is a cartoon from the early days of being a physician when you didn't touch patients. All of those physicians are wearing wigs, and all of them are protecting themselves from humors, you know, the pre-science kind of conception that, ew, patients had these strange liquids and so on that we had to protect ourselves from. My joke about this now is, now it's the patients who are, like me, cancer patients who are wearing the wigs and carrying the canes, and the doctors are now into stethoscopes, except they're into even quicker technology than stethoscopes. So I hope my doctor colleagues here enjoy the cartoon. Okay. You've already heard my story about showing up in an emergency department about 12 hours after I gave a presentation to the Regina Coppell Health Region. And I showed them this slide and said in 2013, given the state of my skeleton, I eventually am going to face a fracture, collapse of the spine, I'll be immobile. Well, 12 hours later, there I was in the emergency department. But most of you have heard that story. I did receive exceptional care. There was an ambulance issue, but in keeping with my no blaming, I'm not even going to go there anymore because I had exceptionally coordinated care. And as a result, I was able to go home without being admitted to the emergency department, simply because that whole team at the Pasco Emergency was doing so well at providing patient-centered care and making sure that they were supporting me as much as possible. Weeks later, with a lower spine ulcer that wouldn't heal, physicians at the family medicine unit recommended that I permit them to do a biopsy. I made a mistake in my last presentation and said autopsy, but because of the potential for cancer progression from my spine. So they received approval from the Alan Blair oncologist, but notice that that was family medicine taking over what would normally be the cancer clinic's role. And that's an example of local innovation where I had 3 physicians and a nurse practitioner comparing notes, looking at their iPhone, trying to figure out, you know, what the correct approach was. And I was so impressed with that there was a local team doing exactly what I needed and coordinating it with the Alan Blair. So I was so impressed. Palliative home care, after I was discharged, provided daily dressing changes. That was the safest, fastest, and most economical care I could possibly have expected, and couldn't get it from anywhere in the rest of the system. So I was pretty impressed, and it sunk into my brain that essentially I was coordinating my care, but the whole team was collaborating with me to provide real patient-centered care. That's the good news, is these people were all motivated by making sure that I was getting exactly what I needed, even if it wasn't their normal role. So slide 14, there's me getting radiation treatment for bone metastases on the inside of my skull that screwed up my vision. So I had double vision until yesterday. And I still have double vision, except I heard about somebody who had their vision corrected with a lens. I went to my optometrist, and he said, yeah, there's something called a Fresnel. It's a plastic lens. And then they contacted my ophthalmologist, who said, no, Lawrence has to wait 3 or 4 weeks. And I'm going, well, that's easy for you to say because I'm disabled. I can't see. There are 2 curbs, 2 cars. You know, I'm at risk of falling. But he was just focused on my eyesight, period, not my skeleton, and probably didn't realize that I was a palliative patient. So a little bit of connections with my team, my family physician, the optometrist again, and bingo, I am now wearing a Fresnel. I didn't even know that such a thing existed. And frankly, people at the Pasco Hospital on the 2nd floor didn't know that they provided this service on the 3rd floor. So it was a really interesting experience where I got patient-centered care after all. I just had to support the people who were helping me navigate it. So I was so impressed, I ended up admitted to the hospital, the general, for an MRI, which revealed the tumor. And then 10 treatments later, I still have double vision, but it's corrected with a plastic lens that took like an hour and a half to assess and install. So am I ever relieved? I get to spend the rest of my life actually seeing instead of staggering around, wondering where the hell I am. When I managed to get out of the emergency department, I'm sorry, when I managed to get out of the General Hospital's overnight care for my MRI, I was able to use my cell phone to organize home assist, to make sure I had a walker, and for them to know that I'd be able to go home even if I couldn't walk. I rented a motorized wheelchair. The MediChair people showed up so that and delivered it. So I ended up getting fantastic care simply because I had the capacity and the support from a number of key people, including the social worker, the whole team, really, to say, yeah, Lawrence, we can provide you with it exactly what you need. 10 radiation treatments ended without improvement to my vision, but I've now got a temporary fix. 2 days later, my blood work revealed dangerously low platelets, so I'm at risk of bleeding because of this progression from my spine to my bone marrow. Those 2 stories demonstrate that many of our goals on this project, namely keeping me and others out of the emergency department that is not the best place for us, avoiding admission if possible, ensuring I had community supports once I was sent home, including home visits, assisted living resources, integrated chronic and primary care, palliative care, all the efficiency of home visits compared to trying to get me, a disabled person, into one of those institutions. It is just such an eye-opener for me that no one, I interacted with every single one of those organizations, and every single one of them thought they were providing me with what I needed. But if you look at them, you can imagine that they couldn't possibly be coordinating my care, because who's responsible for it? So I mean, I've relied heavily on the palliative care group of 5 or 6 people, my family physician, and of course the neurologist, the optometrist, the ophthalmologist. They were arguing. So how does that get solved when those people are arguing? And it's only a patient-centered care approach that actually solved it. So the good news I have for you is we don't need to change the system dramatically. If somebody's coordinating care, because not everybody's as fortunate as I am, and the patient and a consistent provider, exactly how my palliative care nurse works, to coordinate my other care as well, including medication adjustments, consultation with physicians, pharmacy, assisted living. If we can do that for me, why can't we do it for other patients? And the patients who don't have the resources, why can't we designate somebody for them to actually do that coordination? Now I want to share what this combination of a decade of health policy reform enthusiasm and my suddenly very sharpened patient insights that my looming expiry date has produced. One, we need to do a hell of a lot more around screening and prevention. We've got the highest rate of accidents, smoking, deaths from avoidable chronic and fatal illnesses, including cancer, diabetes, cardiac disease. We also have the highest rate of avoidable deaths among all the provinces. Now, most of us in this room are focused on providing acute care and chronic care, but we are spending 95% of our budget on acute and chronic care, and we're missing really boosting the preventative side. I'm dying because I failed to get PSA tests for 5 years. I was so excited and so rewarded with my career that I thought I just set it aside. And I went from normal in 2005, a normal PSA, to essentially a fatal one in 2010. So we have to find a way to dramatically expand our screening and our support for people who are trying to prevent chronic and fatal illnesses. The second thing I wanted to flag is patient-centered care. My theory is that only patient-centered care, as driven by patients and families, genuinely collaborating with health providers, system leaders, can produce systemic change. That's because each organization is incapable of changing itself. It's a well-known principle in quality improvement. Each organization is perfectly designed to get the results it always gets. And yet, I fear that we're not doing enough to partner with other organizations to drive change, because we're not all committed to the same definition of patient-centered care. So I just want to say the Dagnone report, that was what inspired me in 2009. And you know, it's just one sentence. I know you all know it and have read it, but I just want to flag. I call upon health system leaders and healthcare providers to adopt, and practice the values that support a truly patient and family-centered health system. So from my perspective is, it's time. We have to do it, and we have to do it now. Partnerships with patients and families can't, slide number 16, I think. Here's my favorite. We enjoyed your stay. Please tell us about this in the survey. So you can imagine that poor patient isn't going to do very well responding to the survey. And that's part of the issue with we're relying on old data or data that's questionable or that's at least 5 months old, and it's simply not reliable. That's not good. What we need is to be asking patients right away, how is your treatment today? What should we change? And then do it, and then ask them again. In other words, the patient feedback needs to be continuous. We can either do that with specially trained patients, because there are some regions in the province who are exploring that, or patient navigators. Then I knew I was a convert to your positive energy camp when Jose and I invited a maximum of 30 guests to our wedding. I invited more health policy people than family, friends, or former colleagues. So I thought, okay, I guess I'm part of your group, and Mark White is the first one to blame. The other thing I wanted to flag for you is the Mark Lalonde report. It's now the 40th anniversary. We have made very little progress, and I will just, it contains a definition of health that fits so perfectly with patient-centered care and addresses what we need to do outside the acute and chronic care system that I think we need to take another look at it. So I'll just leave that with you as one of Lawrence's favorite documents. Finally, we need to support local and unit-based teams of providers and patients responding to patients' needs. Just like what was happening at the family medicine unit with me, with 3 physicians and a nurse practitioner actually digging deep, figured out what I needed. That didn't come from the top down. That didn't come from the director of family medicine. That came from those 4 individuals saying, gee, this is outside our scope, but this is what Lawrence needs, let's just do it. And I'm arguing that's the support that's missing. We've got great top-down leadership, but we're not supporting local innovators in the same way. Just as a quick aside, given all the boasting that Virginia Mason does about patient-centered care, I contacted them directly, and they admitted that patient-centered care is not a core principle for Virginia Mason. It's in fact a secondary. We hope to achieve patient-centered care, but through efficiency measures. So I'm thinking that's pretty weak, because we've given Virginia Mason lots of airtime when in fact they don't actually have patient-centered care as a core principle, which puzzles me. It's actually the Mayo Clinic that wins all the patient-centered care awards, not Virginia Mason. And I discovered this by being an investigative reporter, so I thought I'd share it with you, because we've been all drinking the Kool-Aid. And the other thing we have to be careful about in terms of dealing with physicians, nurses, pharmacy, everybody, is we have to back off a little on the Kaizen stuff is absolutely correct. Because as one of my fellow directors on the Patients' Voices pointed out, yeah, so why did Toyota get the biggest criminal conviction ever by the United States? It's going to cost them $1.2 billion for deliberately misleading the public about safety defects. So which is it? Kaizen and the Toyota production system is perfect, or is it subject to the same flaws as every other organization that we're wrestling with? So I am excited to say that I have one more thing I want to share with you about this business of partnerships. I was presenting at YMCA founders meeting. I made a contribution to the YMCA and pointed out to them that, gee, they just received funding for housing the homeless in Regina. And their funding is from the federal government. And I asked them whether they were aware of the Emergency Department and Patient Flow project, which are essentially chasing the same patients. And they said, it's not in our strategic plan. So it seems to me bizarre that on the one hand, we have the ED Waits project and Regina Coppell involved in exactly that, making sure that the mentally ill and others like me aren't being improperly showing up in the emergency department. Why aren't we communicate? Why aren't those two organizations who are focused on exactly the same patients collaborating? And when the YMCA said it's not in our strategic plan, that was a clue to me, because there's not a partnership. It's just them driving their strategic plan. Number 17, I think. I'm ready. So we patients like to believe that we're going to leave a legacy. For me, that's this opportunity to share with you my new insights as a result of my experience and my I'm dying for patient-centered care perspective. And as I'm realizing, it's not the quantity of one's remaining time that's critical, it's the quality. So despite the curse of my early expiry date and resistance that each of you encounter when you try to change the system, remember that there's no higher calling and no higher human value than taking care of each other. It's the best possible contribution we can make with our time and our humanity. And finally, to Jose, whose deep love and caring make facing my death so much richer and tolerable. My love, when my last breath escapes me, it will whisper your name. Thank you very much.